And that's a serology that is that of what? That's right, a vaccinated patient. All right, so Sam, note on HDV, Dane particle. This is a defective virus. It needs hepatitis B surface antigen to have an envelope. So indeed, two possibilities. Co-infection, you get them at the same time, or you got one, then you get the other. Is that okay? What we call superinfection. And Sam, when you have co-infection, it's no worse than HBV alone. But you find HDV and antibodies. In superinfection, well, unfortunately, it increases the risk of fulminant hepatitis. So it increases the severity. You were already getting damage with hepatitis B, and now you further add on to the infectivity with hepatitis D. Is that okay? So getting them together doesn't make that much of a difference. It's just it's going to be part of your testing. Whereas superinfection, getting it besides having hepatitis B, after getting it, then it increases severity. Is that good? No, in both. But I'm just saying it's just that you find the presence of hepatitis D, but it didn't worsen your disease. Is that okay? So it's just to make you realize, well, that person has B and D together. Huh? So whereas if it comes afterwards, well, then it'll be bad. By the way, let me put a note further, which is pretty much viremia also can help detect basically active hepatitis versus chronic carrier. And to do viremia, well, in active hepatitis, your viral count is going to be very high. It's going to be greater than 100,000 copies per ml. Whereas when you're a chronic carrier, viremia is there, but it's much lower. It's less than 20,000. So all these, hopefully, they'll answer well that big section where you were asking about hepatitis of microbial origin. With some liver pathology. You're going to be okay between the treatment, a quick review of the micro that goes with it, the serology, and then the classic pathology finding of your microbial hepatitis? That works? Yeah? Because if it's not viral, well, then unfortunately, it's a diagnosis of exclusion. And, as a diagnosis of exclusion, then you have many possibilities. I'm thinking of at least 5 big possibilities. And let me just blow this up too. Maybe check your patient history, because you might find drugs, toxins, that would explain the jaundice. For example, what's a famous drug that might require N-acetylcysteine to be given very quickly before a patient dies of fulminant hepatitis. Paracetamol, absolutely, yeah. Which, by the way, here in the States, we're going to call acetaminophen, huh? Paracetamol. It's the same way we call it in France. We call it paracetamol too, but here it's acetaminophen. So I'll put right here the NAPQE, and the metabolite that is produced by P450s. But there could be many other drugs. You know, methotrexate is a classic for being hepatotoxic. Toxins, it could be mushrooms, like alpha-mannitine is a great one. So a little history might help you find this. What if instead you do an iron panel and you see increased ferritin, increase serum iron, increase percent saturation, decrease total iron binding capacity? You could think of what causing some liver damage, but there's also some heart failure in this patient. There's also a diabetes, a bronze color to the skin, HFE mutations, chromosome 6, it could be a primary hemochromatosis. You just have too much iron being absorbed in the body. Why not? Similar flavor, but you have decreased ceruloplasmin and you have increased urine copper. Exactly, Ala. Then this one is ATP7B on chromosome 13. That's defective. And you have Wilson disease. Remember, hepatolenticular degeneration, the famous Kaiser-Fleischer ring. You remember those? Around the decimate membrane of the iris. And if here your treatment is deferoxamine as an iron chelator, what is the classic treatment for Wilson disease? Not sure? Penicillamine. Do you remember penicillamine? To grab copper? Rings a bell? It's also an old drug that was used in rheumatoid arthritis. Huh? What if my patient also has emphysema? Alpha-1 antitrypsin deficiency, maybe with the protease inhibitor allele that's called the Z allele. And if you're homozygous for that Z allele, is when you're going to have panacenar emphysema at the same time. No good treatment for this one. No? You know, another diagnosis of exclusion would be check potentially autoantibodies. And you might have an autoimmune type of hepatitis. Autoimmune type of hepatitis. So, for example, liver kidney microsomal type of antibodies. So, LKM antibodies, that would be a great one. Positive ANAs. So, anti-nuclear type of antibody. Maybe it's a lupus patient. So that's when it would be not viral. Well, if you contrast quickly, we've seen some great example, of course, earlier on, which is cholestatic type of jaundice. And there, what you would do is number 3, you would do imaging you would do imaging, starting maybe with something as simple as ultrasound, to check out the diameter of the common bile duct. Yeah. And when you look at the common duct, you'll end up with two groups of patients.